Penicillin allergy is the most commonly reported drug allergy in the United States, with a prevalence of 10% in the outpatient population and up to 20% in the inpatient population. However, more than 90% of the patients that report penicillin allergy are not truly allergic. Being labeled as penicillin allergic is not a benign finding and has serious implications. Due to the possibility of an allergic reaction, most of the times providers opt for treating patients with an alternative antibiotic, which in many opportunities is more expensive, has broader spectrum, and in occasions could have a lower safety profile and be less effective. The medical costs of patients labeled as having penicillin allergy are higher when compared with those of patients without a history of penicillin allergy. This has been proven in inpatient and outpatient settings. As previously exposed, one reason for this discrepancy is that patients with a history of penicillin allergy are more likely to be treated with more expensive broad-spectrum antibiotics such as quinolones and vancomycin. In addition to financial costs, clinical care can also be compromised because the use of broad-spectrum antibiotics leads to the increased development of multiple drug-resistant bacteria. For all the reasons previously exposed, it is our duty to continue to educate physicians and other providers regarding the implications and importance in recognizing those patients inappropriately labeled as being penicillin allergic. This label influences the treatment selection and, in consequence, patient care. Most of the time, the history of penicillin allergy is unreliable and very nonspecific. When questioning a patient about drug allergies, it is important to query about what medication they develop a reaction to and what was being treated, route of administration, type of reaction and severity, time course, previous reactions, intervention to treat the reaction, concomitant medications, previous testing, and subsequent exposures. The most common allergic reactions to penicillin are the type 1 hypersensitivity reactions, or IgE-mediated. They usually happen within 1 hour of exposure, and these include urticaria, angioedema, bronchospasm, and anaphylaxis. Patients with reaction history compatible with a potential IgE-mediated mechanism might undergo penicillin skin testing. There are also very important non-IgE-mediated reactions that you need to recognize and remember. These include drug-induced hemolytic anemia, allergic interstitial nephritis, Stevens-Johnson syndrome, toxic epidermal necrolysis. These are absolute contraindication to penicillin, and patients that have developed this in the past are not candidates for skin testing or challenge and should avoid penicillins indefinitely. Why most patients with a label of penicillin allergy are able to tolerate penicillins? Potential reasons include the following. Multiple times the reaction was mislabeled as allergic. For example, a patient experienced nausea or diarrhea. These are most likely adverse reactions. Sometimes the symptoms were attributable to an underlying illness or an interaction between the illness and the antibiotic. Levels of penicillin-specific IgE wane over time, and penicillin allergy is commonly, but not always, outgrown. Positive skin testing decreased by 10% annually after penicillin allergic reaction, and 80% of penicillin allergic patients have a negative skin test after 10 years of avoidance, meaning that penicillin allergy is not permanent. Who should you refer for allergy skin testing? Patients with a history of classic IgE-mediated reaction, including urticaria, angioedema, or anaphylaxis. Patients labeled as penicillin allergic with recurrent use of antibiotics due to multiple infections. Patients with unclear history of past penicillin reactions. Remember, penicillin skin testing should be performed only by allergy specialists in the inpatient or outpatient settings, as patients may develop serious allergic reactions during testing that need prompt management. Penicillin skin testing is a standardized and reliable tool to assess for IgE-mediated reactions to penicillin. It is a rapid test with only minimal discomfort and highly accurate. On the basis of studies conducted in the US, the negative predictive value of penicillin skin testing is greater than 95%. The products used include pre-pen, penicillin G solution, and a positive and negative control. Remember, if this test is negative, you can use penicillin, knowing that the patient has similar risk to general population of developing an allergic reaction. Besides penicillin skin testing, we also have the option of doing graded drug challenge, also utilized to work up penicillin allergy. It is used if a patient is unable or unwilling to do skin testing, the history of allergy seems recent or concerning and yet penicillin skin testing was negative, or in the case of cephalosporin allergy with questionable history. The challenge can be administered stepwise with a gradual administration of the drug. In some cases where suspicion for a true allergy is very low, some physicians opt for performing drug challenge as the initial intervention for assessing penicillin allergy, therefore skipping skin testing. Now, let's review some concepts regarding penicillin cephalosporin cross-reactivity. Penicillins and cephalosporins share a common beta-lactam ring, and hence there is a potential for IgE-mediated allergic cross-reactivity. The rate of cross-reactivity is controversial, but most authors agree that it is overestimated. Clinically significant cross-reactivity is infrequent. A review of cross-reactivity of second and third generation cephalosporins revealed no significant increase in allergic reactions in those patients with a history of penicillin allergy. If a patient is given a second or third generation cephalosporin without penicillin skin testing, the estimated reaction rate is of less than 1% and 2 to 4% with a positive skin testing. And this rate is even lower when you administer a fourth or later generation cephalosporin. With this, we conclude that not all the cephalosporins are contraindicated in patients with penicillin allergy. Actually, there are 4 possible management options for the administration of cephalosporins, and these include to administer the cephalosporin without any testing, given the fact that the incidence of cross-reactivity is very low. In most cases, this will not lead to a serious adverse reaction, but the chance of one is always present. Have a special caution with patients that have reported a severe or recent reaction. The second course of action will be to skin test to penicillin, and if negative, go ahead and administer a cephalosporin. This is probably the most widely accepted management strategy because most patients have negative test results and can receive all beta-lactams safely. The third way to manage this patient is by skin testing to cephalosporin and follow this with a graded challenge. But cephalosporin skin testing is not standardized and has unknown negative predictive value. And finally, an option is to avoid all cephalosporins altogether and treat with a non-beta-lactam antibiotic. The caveat to this approach is that many times this will lead us to use a more expensive broad-spectrum antibiotic with a lower safety profile. In summary, we want you to remember that the label penicillin allergy is not benign and it has severe economic and microbiologic consequences. More than 90% of patients that report penicillin allergy are not truly allergic, which means that they have a negative skin testing to penicillin. Penicillin allergy is not permanent, it fades over time, and about 80% of patients will grow out their allergy in 10 years. Skin testing is the most rapid, sensitive, cost-effective testing modality for evaluating patients with immediate allergic reactions to penicillin. And the cross-reactivity between penicillins and cephalosporin when a patient has not had skin testing is less than 1%. Thank you for participating in this educational initiative.